This topic is very confusing and very controversial as well, so I hope I don't offend anybody. It's also confusing to pathologists. So everybody is a little bit confused by this, but hopefully we can start to make sense. And I do think the field is solidifying so that the terminology is starting to become more standardized and widely adopted. So the title of the talk is Making Sense of the Alphabet Soup of Appendix Cancer Pathology. Okay, so I'll briefly talk about some problematic terms, and we'll go quickly into classification of the primary lesions. We'll focus today, as you know, on appendiceal mucinous neoplasms and also on Pseudomyxoma peritonei. And I'll give you some examples that we've seen of clinical and biologic spectra that I hope will help us to start understanding better classification of this disease. So as Dr. Lowy mentioned, we have PMP, also known as PP. We have DPAM. We have lamin, my personal favorite. We have LG-MCP, and you can't have LG-MCP without having HG-MCP. And then everybody's favorite, PMCA. And then also, if you don't like that, then you've got MTUMP. I haven't even included MLUMP. So all of these things, we're going to figure these out, and it'll be perfectly clear. So before we even get to the classification systems and kind of where we've come when classifying these lesions, I'd like to discuss briefly some of the confusing terms. The first of these is mucocele. So mucocele is defined as a dilated appendix filled with mucin. It's not a specific pathologic diagnosis. And it can be due to various different things. Some people, when they say mucocele, they say, oh, that's benign, that's a retention cyst. Some people, when they think mucocele, they say, oh, that's always neoplastic, and neither of those is true. We can have both non-neoplastic and neoplastic causes of mucocele. So the causes usually are epithelial proliferations in the appendix. You can have hyperplastic polyps causing this. You can have adenomas. You can have lamins or low-grade appendiceal mucinous neoplasms, which we'll talk a lot about today. Invasive adenocarcinoma, and uncommonly it can be caused by inflammation, endometriosis, fecalis in the appendix, or other causes. Therefore, it's not always malignant or even neoplastic, but usually is. So here's an example of a mucocele. And so you can see the surgical field there and a very dilated appendix with some mucin extruding from the middle portion of that. So definitely mucocele. Neoplastic? Maybe, possibly. In the bottom left, we have a CT image of a mucocele. You can see this very round, dilated structure adjacent to the large bowel right here. And when you start getting above 1.5 centimeters, then it's usually neoplastic. If it's over 2, it's almost invariably neoplastic. Another term that is very confusing and very important for today is Pseudomyxoma peritonei. Again, this is a clinical syndrome, a clinical diagnosis, but not necessarily a specific pathologic diagnosis. It's defined as accumulation of mucin within the peritoneal cavity, usually secondary to a spread of a mucinous neoplasm. Classically, a long time ago, it also referred to those lesions that may not even have had neoplastic cells. So again, possible causes are variable. Usually this is caused by a low-grade appendiceal mucinous neoplasm with high risk of recurrence. Sometimes it's caused by those with low risk, or by mucinous adenocarcinoma of the appendix or other sites. And then rare causes include things like intestinal-type adenocarcinoma arising from mature ovarian teratomas, ruptured pancreatic IPMN, and other rare cases. So the final confusing term that I want to highlight is the term appendix cancer. As you know, there are various different cancers of the appendix, and it's not a specific pathologic diagnosis, of course. And so when I see that on a report, or if I see that somebody just says the term appendix cancer, that could be anything to me. That could be any appendiceal neoplasm. So when I see that, I want to investigate further. By itself, it doesn't mean anything. And unfortunately, there are misdiagnoses where there are overcalls where the cancer wasn't actually present. So just to remind you, the primary appendiceal neoplasms that we have can be malignant or benign. You can have standard adenomas that you would see in the colon, although we see those very uncommonly. We have low-grade appendiceal mucinous neoplasms, which can represent 20 to 50% of appendiceal malignancies, depending on the case series. Adenocarcinoma is a little bit less prevalent at about 10%. And the vast majority are actually neuroendocrine tumors. Some of these very, very small. When they're less than 1 centimeter, they're almost invariably benign. And then you have very rare things like goblet cell carcinoma, goblet cell carcinoid, and carcinoma ex goblet cell carcinoid. And then again, I want to make sure that we remember that you can have a simple mucocele or retention cyst that's completely benign and non-neoplastic. So today we'll focus primarily on the lamins and mucinous adenocarcinomas. So classification of appendiceal mucinous tumors. So a little bit about the history and philosophy behind it. It's been known that mucinous tumors of the appendix can penetrate into or through the appendiceal wall and into the peritoneum. That's been known for a long time. Given the low-grade cytology of many of these lesions, they look like adenomas. Some consider these as ruptured adenomas extending into the peritoneum and behaving better than carcinomatosis, so real invasive cancer in the peritoneum. Others hold that the ability to disseminate in the peritoneum is a sign of malignancy, and the findings in the appendix are pushing invasion. And because of the intermediate nature of these lesions, various terms have been proposed. So back in the 40s and through the 70s, terms that were used were things like benign mucocele if it was contained in the appendix, or cystadenocarcinoma if it extended into the peritoneum. Then realizing that the neoplastic nature of these lesions, the term cystadenoma was actually brought on later for those lesions that were confined to the appendix. And here's where we get into our alphabet soup again. MTUMP is mucinous tumor of uncertain malignant potential, and that's from Carr and Sobin in 1995. And that referred to those lesions that were confined to the appendix. So they thought that if it was outside of the appendix, it's automatically adenocarcinoma. More recently, lamin, the term low-grade appendiceal mucinous neoplasms, has been used. Mizrahi and Yantis in 2003. And then those lesions have been risk stratified into low risk and high risk of recurrence based on work done by Ritesh Pai and Terry Longacre in 2009. And as you'll see, this is the stratification that we typically use. So what does lamin look like? The histomorphologic features are thus, and we have a couple pictures on the left for you. It's a neoplasm composed of a single layer of flat cuboidal or columnar cells with villous, flattened, or serrated morphology. They may have large mucin vacuoles. They have intestinal differentiation, so they often have goblet cells. And they're usually circumferential in the appendiceal lumen. They have this pushing or broad front invasion. So if you can see here, this is a more undulating profile to the epithelium. So these are malignant or low-grade dysplastic cells here. These are also dysplastic cells. But you'll notice that underneath the cells, this is not your normal lamina propria of the bowel wall. This is actually somewhat hyalinized and fibrotic. So the thought is that some people interpret this as pushing or broad front invasion. I actually have a different theory about it, and I think it's due to pressure atrophy. But this is not your typical desmoplasia that you see in invasive adenocarcinomas. So also, we can use immunohistochemical features to analyze these lesions, although typically we don't need to. A standard hematoxin and eosin stain is sufficient. These tumors are CK20 positive, just like colon cancer. However, in contrast to colon cancer, 25 to 40% can be CK7 positive. The case that you see on the left is an immunohistochemical stain for CK7. In this case, is actually negative for CK7 and positive for CK20, so that's the typical staining pattern for these lesions. They also have their own specific pattern of mucin stains. So CDEX2 and mucin are intestinal markers, and they're universally positive in these, so it's an intestinal differentiation. MUC5AC and MUC6 are variable expression. We see those in what we call pyloric differentiation or gastric differentiation. So these are the classification systems that have been used. So as I mentioned, Carr et al. Carr and Sobin is the earlier one with the MTUMPs. Mizrahi, Pai, and World Health Organization all have similar classification systems, and I'll kind of show you how we utilize these at UCSD as well. So tumors without invasion have been variously called adenomas, low-grade appendiceal mucinous neoplasms, when they're entirely contained within the appendix and within the muscularis mucosae, so the most superficial layer of the appendiceal wall. Tumors with so-called pushing invasion, again, I personally don't believe in pushing invasion. I believe it's pressure atrophy and rupture. Those tumors that are confined to the appendix are variously called lamin and mucinous tumor of uncertain potential. Tumors with acellular mucin outside of the appendix and tumors with extraappendiceal mucinous tumor have variously been called mucinous adenocarcinoma in the Carr system, if there's extraappendiceal tumor. Low-grade appendiceal mucinous neoplasm for Mizrahi, and then in the most recent, by Pai and Terry Longacre, is high risk of recurrence. So this is where the real difference is. So lamins, regardless of, so Mizrahi basically uses lamins for all this intermediate range lesion, but PI will actually distinguish between those that have extraappendiceal mucin and those that don't. So those that, irrespective of acellular mucin, if there's cellular mucin, these lesions will be high risk. If there's not, then they're considered low risk, and I'll show you the data for that. Regardless, if the lesion has infiltrative invasion or destructive invasion, meaning desmoplasia or invasion into other tissues, then it's always called adenocarcinoma. So these are some of the data. I'm not going to go into this from the Pye and Longacre paper. I'm not going to go into this in too much detail here, but basically, by definition, the key thing I want to draw your attention to is these two middle groups, the lamina with low risk of recurrence and lamina with high risk of recurrence. So you'll notice that by definition, extraappendiceal epithelium is absent in the lamins with low risk of recurrence and is present in those with high risk of recurrence. So what does that look like? This is a lamina with low risk of recurrence. It is circumferential in the appendiceal lumen, so this is a cross-section of the appendix. And you see the neoplastic proliferation in the lumen of the appendix. This case actually has extraappendiceal mucin here, but no cells in the mucin, so this is still low risk of recurrence. So all this cellular material here are inflammatory cells and histiocytes, so no neoplastic epithelial cells. So it does have cells, technically speaking, but not those of interest, the neoplastic cells. This is another cross-section of an appendix with some dissection into the wall here, but no desmoplastic invasion. So this will be low risk of recurrence. Conversely, if you have extraappendiceal mucin with cells, so right here we have abundant extracellular mucin, and then these are the strips of neoplastic cells outside of the appendix. So this would be high risk of recurrence. Now, if this lesion somewhere else shows destructive invasion into tissues, then it's progressed. And perhaps the better designation would be invasive mucinous adenocarcinoma. So these lesions specifically lack that. Okay, so why does this matter? It affects outcomes. So on these graphs, we have Kaplan-Meier curves for overall survival and disease-free survival. So if you look, what they called adenoma or lamina with low risk of recurrence had 100% disease-free survival here at a very long time course. However, if there was a high risk of recurrence, so extraappendiceal cells, there was a drop-off here, and then mucinous adenocarcinoma had the worst prognosis. So no survivors at 6 to 7 years in this group. So we can see that this dichotomizes the two groups very well. So this is a very low risk group here, and this is a very high risk group here. So factors that decrease overall survival in this series is extraappendiceal neoplastic cells, high-grade cytology or complex architecture, which we'll look at later, and an overt invasion, which would make it adenocarcinoma. And more diffuse peritoneal spread is obviously something that we think would be a worse prognosis overall, and it trended towards significance here, but was not statistically significant. So the UCSD approach on these primary lesions of the appendix, the term adenoma is used very rarely. We don't see them too often, and often they're a part of the appendiceal orifice. Low-grade appendiceal mucinous neoplasm is preferred even for lesions that seem to be confined to the appendix. And the reason is that unless you're 100% sure that it hasn't perforated the appendiceal wall, then you could have peritoneal spread. So in pathology, we always submit the entire specimen throughout because we don't want to miss small areas where it's extended to the serosal surface. So rupture, pushing invasion, and or extraappendiceal epithelial cells are not sufficient for a diagnosis of adenocarcinoma. Neoplastic lesions with destructive invasion, including overt or desmoplastic reaction, should be called adenocarcinoma. Mucoceles are not necessarily neoplastic, but may be retention cysts. And lamins are additionally risk stratified according to Pye et al. Into low and high risk of recurrence. So we use WHO and Mizrahi. Then on top of that, we do the risk stratification according to Pye et al. Since it seems to have such good discrimination between high and low risk groups. So with that, so we have two parts of this, right? We have the primary lesion, and then we have the extension into the peritoneum. And so again, this is a confusing term, and there are classification systems for PMP. So a little bit of the history. So this was initially described by Wirth in 1884, and historically the term has been used to refer to peritoneal mucin regardless of its source, whether it had neoplastic cells or not. Classically consists of abundant mucin with scant strips of neoplastic and highlighted fibrotic stroma, and that's usually secondary to a lamin or low-grade appendiceal mucinous neoplasm, as we talked about, and there's no desmoplasia. It can also be high-grade with complex architecture or high-grade cytologic atypia, and that's usually secondary to a mucinous adenocarcinoma that could be from the appendix or other areas of the GI tract. So the terminology that was used is DPAM and PMCA. We tend not to use those in pathology and prefer the LG or low-grade and high-grade mucinous carcinoma peritonei according to the WHO. The idea behind DPAM is disseminated peritoneal adenomycinosis was that you had this adenomatous epithelium that's very bland in the appendix, but it could rupture and extend and grow into the peritoneum. So they wanted to acknowledge the low-grade nature of the lesion and did not want to call it carcinoma. Whereas the term peritoneal mucinous carcinomatosis referred to those things that were definitely high grade that looked like adenocarcinoma. So again, that two-stage system is still being used, perhaps with slightly different names, and I can show you kind of how we do that right here. So these are different classification systems. So on top, we have Runette, Bradley, and Mizrahi, and then we have WHO 2010 at the bottom. And WHO is primarily based on Bradley et al., but it is slightly different if you look at the details of it. So I'd like to focus primarily on the mucinous carcinoma peritonei low-grade and high-grade. So the Bradley et al. And the WHO, because that's the system that we use here at UCSD. So in the low-grade, it's defined as scant cells in abundant mucin. They have a low-grade cytologic atypia, and they can be very bland. They can almost look like normal epithelium, just in the wrong place. Intracytoplasmic mucin is variable. In high-grade lesions, according to WHO, you can have cells in strips, small islands, or more complex structures, so they become cribriform or very proliferative. The cellular content is higher, so there's more cells per unit of mucin. And there's also can be invasion into underlying organs. You have high-grade dysplasia, and you can see signet ring cells. So the UCSD approach, here, let me show you this picture first. This is actually from the WHO. So low-grade mucinous carcinoma peritonei has these scant strips on fibrotic stroma. Here's the mucin right here. So it looks very similar to the lamin. And when lamin extends in the peritoneum, this is how it extends. High grade, as you see, has more complex architecture. So here's an example of a cribriforming nest. And then you can also have signet ring cells as well. So the UCSD approach is to use the WHO 2010 criteria with the understanding that this is a spectrum of disease. And it's sometimes hard to separate out low and high grade. And even Sugarbaker himself acknowledged that these were all a spectrum of disease. So sometimes we have intermediate atypia or intermediate grade of the mucinous carcinoma peritonei. And so we'll say something like, low-grade mucinous carcinoma peritonei or mucinous carcinoma peritonei with focally increased cytologic atypia or something like that if it's doesn't quite meet criteria for high-grade mucinous carcinoma peritonei. Florid peritoneal or capsular disease is insufficient for a diagnosis of adenocarcinoma. A lot of times on the surface of the spleen or other organs, we'll see huge aggregates of mucin and neoplastic cells. However, there's no invasion to the underlying tissue. If there's frank organ invasion, we actually call this adenocarcinoma, and that usually correlates to the clinical impression. So here's kind of a confusing slide, but I think helpful. It might even be partly accurate. So the classic case is up here. So this is relatively easy here. So if the primary lesion in the appendix is a lamin, the peritoneal extension is usually low-grade mucinous carcinoma peritonei. Some groups will call it involvement by lamin. but that requires that you have knowledge of the primary lesion. And in our referral center, we often get cases where we don't have the primary lesion, we just have the peritoneal extension available for pathologic review. So I actually like this term over involvement by lamin because it allows us to not have to have knowledge of that prior lesion. Regardless, if you have a low-grade adenocarcinoma or a high-grade adenocarcinoma, things get more complicated. So a low-grade adenocarcinoma that's truly invasive can have a peritoneal extension that's low-grade, a peritoneal extension that's high-grade, or frank invasive carcinoma. And again, for a high-grade adenocarcinoma, it usually has high-grade extension, and that would look like high-grade mucinous carcinoma peritonei or carcinomatosis. And then the other thing that we're seeing now, since we have improved treatments, is that it looks like sometimes there's a potential that low-grade can progress to high-grade and progress to carcinoma, potentially. This is a question mark here. So it may be possible for there to be progression of disease over time. So examples of spectra of disease. This actually is a little bit of a complex case. We have a possible lamin here versus an adenoma in the appendix. The reason why there's a little bit of an ambiguity is that lamins typically will have that pushing front and be sitting on a fibrous stroma. Here, there's a little bit of inflammatory cells here, so it could be interpreted as a lamina propria. So this could be a lamin or potentially an adenoma. Regardless of the precursor lesion, this case actually had frank invasion. So here we have overtly invasive adenocarcinoma. See all these cells here? They have very large nucleoli, small angulated glands, and individual cells invading through the bowel wall. So this is frankly invasive adenocarcinoma. And this focus right here is a peritoneal implant. So this is kind of an intermediate grade. If you think back to the low-grade and high-grade mucinous carcinoma peritonei, this is kind of an intermediate grade extension of the tumor. But we have frank invasion, so this would be adenocarcinoma. We also have, if we hear the term mucinous cyst adenocarcinoma, you think about an ovarian primary. Here we have a mucinous neoplasm up here coating the surface of the ovary down here. So these are ovarian stromal cells. And so classically, it was thought, there was a big debate right in the literature about appendix versus ovary causing pseudomyxoma, right? And that was resolved in the 90s, that these are almost invariably appendiceal primaries that are causing pseudomyxoma. So that's why it's in quotes, not really cyst adenocarcinoma. But what's interesting is how lamin can mimic so many different things. So this is the ovary, and the lamin is coating here, and it looks like it's invading into the ovary, but what's happening is that this very thin epithelium here is an ovarian inclusion cyst. So the ovary can get little inclusion cysts on the surface, and the lamin is growing right down into it. So it's mimicking invasion into the ovary, but it actually is not an ovarian primary. Here was the peritoneal disease there. So here's, in the upper right is the bowel wall, and this is actually on the peritoneal surface of the bowel. You can see how low-grade and mucinous appearing that epithelium is. And then when the appendix was evaluated, just like we expected, there's low-grade appendiceal mucinous neoplasm in the appendix, so very florid. Here's a close-up view. Here's the neoplastic epithelium. And here's that pushing invasion, so-called pushing invasion, which I think is pressure atrophy, causing kind of a squishing of the muscularis mucosae there. And here are submucosal vessels that are kind of flattened because of the pressure. So this lesion had ruptured and extended into the peritoneum, involved the ovary, and mimicked a mucinous cystadenoma of the ovary. It should be noted that these lesions are different than right-sided colon cancers. So right-sided mucinous colon cancers are often associated with mismatch repair deficiency or Lynch syndrome. In contrast, these mucinous tumors, although they're right next door in the appendix, right, these mucinous tumors of the appendix are usually intact for MLH1 and other mismatch repair proteins. So this is an immunostain for that mismatch repair protein. It's highlighting the nuclei, and it is intact, so it's normal. On a lighter note, we have the other end of the spectrum, right? We have simple mucoceles that are non-neoplastic. So you can see on low power, this is a dilated appendix. And we have flattened epithelium, but this is actually normal. There's normal crypts there. And so this is a non-neoplastic mucocele. Here's another example of a non-neoplastic mucocele. Unfortunately, sometimes these are misdiagnosed or overcalled as lamin, right? And we've seen cases where if one of these ruptures, then what's going to happen? You have either a benign non-neoplastic appendix with rupture and extraappendiceal mucin that's totally non-neoplastic, but that could potentially be miscalled as a lamin or something worse with high risk of recurrence. So it's very good to get a second opinion on these things and definitely have a subspecialized GI pathologist look at these cases. We've seen it be a very challenging area for pathologists as well. So in summary, appendiceal mucinous neoplasms have confusing biology and terminology. Lamins behave according to whether there's extra appendiceal mucin. That's a huge prognostic factor. Adenocarcinoma has destructive invasion, obviously has a worse prognosis. Pseudomyxoma peritonei is divided into low grade and high grade according to WHO. There are newer systems coming out that divide into 3 categories, but those aren't as well established yet. Wide adoption and understanding of standardized neoplastic and non-neoplastic terminology is needed to avoid diagnostic error. And we may be able to improve risk stratification using molecular and immunohistochemical techniques. So Olivier will actually talk about some of the genetic changes in these lesions. And my hope is that looking at the histology, getting a good framework there, looking at immunohistochemical techniques that look at the proteins in the lesion, and then looking at the genetics, together we'll be able to come up with a better stratification of risk for patients. So with that, I thank you very much for your attention.
You had mentioned that your philosophy in terms of the pushing versus the pressure was different. Can you expand on that a little bit?
Yeah, so I think that the term pushing invasion, I'm not really sure what that means. So pathologists use that term, pushing invasion, but I don't know the biological mechanism. I don't know how that would even work. So in these lesions, they have genetic mutations that overproduce mucin and cause tremendous pressure to build up in the appendix. So the expectation is actually there would be pressure atrophy around these lesions. And so that's what I think is happening, and I think we actually see it when we look at the tissue, that there is evidence of pressure atrophy, including necrosis and fibrosis of the underlying stroma. So effectively, it's somewhat it could be a semantic argument, right, that pushing invasion is the same as pressure atrophy by a neoplasm. But to me, it also points to the biologic potential of the cells themselves. So if a cell is wildly malignant and can invade tissue and metastasize hematogenously, that has a certain biologic potential. These cells don't have that potential. They have the potential to secrete a lot of mucin, cause the appendix to rupture, and they have the ability to also live on a different type of stroma. So I think they can live in the peritoneum. So they generally don't spread to lymph nodes, right? So they don't spread hematogenously. So that points to a different biologic potential to the lesion. I don't know if that really answers your question. So it could be semantic, but I don't want to call something invasion when it doesn't have the capacity to invade.